Yeah, hi again. I'm going to start doing some of these. I may have to do this in yet a third part because we haven't quite gotten to all this stuff yet. But I will start with the antibiotics in an effort to make sure that we get all this material and you have adequate time to review it. So, without any further ado, the things that you have to understand since we've hit antibiotics, what an antibiotic is, it's naturally occurring and it's produced by some type of mold or bacteria. So it's a microbial agent that's naturally produced by other microbial agents, such as, particularly for our purposes, bacteria and mold. And they do one of those two things: either grow or kill microorganisms. There's a lot of definitions as part of this unit as well. Another one is bactericidal versus bacteriostatic. Okay. Bactericide is very straightforward. It's like being homicide, patricide, matricide. Side means to kill. This kills bacteria. These are the desirable agents because we want to kill the bacteria, particularly cell wall agents and a few of some other categories, as opposed to bacteriostatic, the bulk of the agents that fall into attacking the ribosome, the 70S ribosome, because they basically just inhibit the growth cycle. Once you take them away, they start to grow again. And so then you're basically facilitating your immune system's response to it. That's important. Selective toxicity. What does it mean? It's more likely to kill the microbe than the host. Okay. It doesn't have to do with all the different types that they kill. It's all about more likely to kill the microbe than the host. That's what selective toxicity means, pure and simple. It's the idea, its therapeutic index is such that it has a high therapeutic index or a broad safety margin because the lethal dose for 50% of the population is considerably larger than the effective dose. That's really what everything else is about when we look at selective toxicity and therapeutic index. That's what makes agents desirable. It's really important. It doesn't speak to a whole lot else. Again, it's more or less a statistical measure. Half life. Half life, by definition, is the amount of time needed for the host to metabolize or break down one half of the antibiotic dosage given. The nuance, this interesting thing about half life in pharmacology, is it's broken down or disorganized in some way, shape, or form the agent. It doesn't mean it renders it impotent. It doesn't mean it doesn't render it unable to do its job. A lot of things have active metabolites. So we tinker with half life scientifically so that so it facilitates our usage. So we don't have to. For years, antibiotics were 10 days, 4 times a day. You don't get a lot of compliance. You like agents that you take once a day, even twice a day, or even 3 times a day. Take it with meals, that type of thing, because you get better compliance. That's really important, particularly when you're dealing with people who don't like to take pills, senior citizens who hate to take pills. I'm one of them. Where you get that stupid container with all the 16 pills, and I can't tell you how many times I turn around and go, I am so sick and tired of taking pills. So if you just have to take one or two, it's a whole lot easier. That's why that's important. Everybody gets adverse effects, what we call side effects, and allergies confused. They are not the same. Allergies, rash, swelling, difficulty breathing. Sometimes it's gastrointestinal, but much less so. What it indicates is very much this: an allergic reaction is due to excessive activity of your immune system. Nothing else. Okay, it's an immunological response to the agent you're taking, and it can happen anytime. You could have taken it 28 times and never had a problem, and the 29th time you have a problem with an antibiotic. Think of it, amoxicillin. Maybe you've taken it many, many times when you were younger for your infection. All of a sudden, you have a reaction. That's what happens. They can both allergic responses are not necessarily more severe than side effects. They both can kill. Okay, okay. So understand that we only distinguish them by how it happens. Okay. Everything else, if it's not an allergic response, is a side effect. Headache, diarrhea, constipation, gastrointestinal, feeling funny, can't concentrate. All of those things, if they're not distinctly known as being allergic responses, they are then side effects. And time's not an issue either. You can have an allergic response delayed or you can have it immediate. So understand there's a whole lot between that. When we talk about broad spectrum agents, that means they target both gram positives and gram negatives. Inevitably, they target useful bacteria in your gut. And what happens that they suppress the growth of those and they permit something like C. diff, Clostridium difficile, to flourish. That's the big issue with broad spectrum agents. Why we have to be so careful, why we don't want to overuse them. And there's a lot of other reasons as well. Consistently, the best group of agents are cell wall antibiotics, so they target in one way, in any shape, way, or form, the assembly or the development or the maturation or whatever you want to call it with peptidoglycan. So know all of those: penicillins, cephalosporins, vancomycins, the ones we talked about a lot. Are there others? Yeah. Is bacitracin in there? Yeah, but it's topical. Things like macrolides, tetracyclines, aminoglycosides, those are all agents that target, and that we've talked about recently, that target the 70S ribosome. They are not cell wall antibiotics. So when we look at penicillins and cephalosporins, by definition, and there's a couple of others, the aztreonam was in there, but they are called beta-lactam drugs because they have that beta-lactam ring. You don't have to know the chemical structure, but that's the structure that interferes with the assembly of peptidoglycan, and that's there. So any enzyme that targets that ring structure of the penicillins, by definition, is called a penicillinase. Beta lactamases are similar, not necessarily identical to that, but because they can have other effects. So their terms are not interchangeable, nor would I ask you a question like that. But penicillinases specifically target the ring structure of penicillins. Beta lactamases may be more commonly associated with targeting cephalosporins or other agents for that matter, or they may not necessarily be produced by staph. They are produced frequently by non-staphylococcal organisms. We talked about augmentin. It's a combination of amoxicillin and clavulanic acid that works synergistically. That's what it does. Is it useful for MRSA? No. Okay. Understand, when we start talking about MRSA, which is part of tomorrow, and I'm dictating today on the Tuesday, Wednesday's discussion, those other agents that are there, it's not so easy to deal with. Okay. So again, um, methicillin, okay, is defined as the agent that almost created MRSA. That's there. That's why we call it methicillin-resistant Staphylococcus aureus. You have a limited subset of agents, and basically the penicillins no longer work for that. The same thing with allergies. If you're allergic to penicillin, you're allergic to amoxicillin, you're allergic to methicillin, you're allergic to ticaricillin, because they're all made from the same base product. You don't want to use it. The crossover, the cross reaction with cephalosporins of about 10%, because they're both from mold and they're somewhat similar families of mold, if you want to think of it that way. But what is their advantage other than that cross reactivity? Okay, they are less affected by beta lactamases. They are inherently broader in spectrum. They can go have a better chance of taking care of gram negatives. That's why we love them. That's why they're the first choice family of antibiotics, by and large, with the exception rather of people who are allergic to penicillin. Aminoglycosides were great for gram negatives. Trouble had a lot of side effects, particularly hearing and kidney, oto and renal toxicity. So we have to be very careful using them. What we basically use them for, probably more than anything else these days, is Pseudomonas. We have to use them by injection. The agent is called gentamicin, but you always are monitoring that kidney function. Remember, I talked about the BUN and the creatinine levels on blood tests, typically every other day, because typically the injections are given I recall on a daily basis, sometimes a twice daily basis. Certainly in the hospital, it may be a little bit different with home care. And again, there's more home care than you think these days. And for you going into nursing, that's not a bad job, by the way. You like to be in the car and getting about, meeting different people, being a nurse that travels, being a nurse that does home care, being a nurse that does that kind of stuff where you like to move around and do that stuff. There's a lot of opportunities that are out there. My first wife did was work for insurance companies, basically trying to get people back to work. You're really to some extent you're employed by the insurance company, so you're pushing people back to work. People don't like that. She didn't. Okay, but oh god, travel and pay and we stay in nice places and a lot of socializing with people. For she liked that part of it, but not the patient interaction. Macrolides. That's the category that has erythromycin and now azithromycin, the Z pack. You must be aware of that. Okay, being the drug of choice for people who are allergic to penicillin. Again, that's still the important feature of it. We use it a ton, but that's really what's important. Down the road, we're going to get to fluoroquinolones. That'll be on Wednesday. That's where Cipro comes in. Ciprofloxacin is really important because it's great for gram negatives. It has very limited effect on staph and strep. Interestingly, other gram positives, it has plays kind of a role in. We're going to talk about combination sulfa drugs, particularly trimethoprim and sulfamethoxazole. So that is a very interesting drug that has a unique pathway called folic acid inhibition. I talked about it a little bit in one of the recorded lectures that I sent to you. We do not have that pathway. The only way we can get folic acid, we can't make it inside. We have to ingest it. So it's effectively in the B vitamin category. And it's necessary for the assembly of nucleotides. Those wonderful A's, T's, G's, and C's plays a role in that. Bacteria make that folic acid and they have a distinct pathway. These are two agents that are in the sulfa drug category that inhibit, and you'll see exactly where they inhibit that pathway. It's still bacteriostatic more than anything else. Where ciprofloxacin, that's fluoroquinolones, is bactericidal. That's why it's a good drug, and we'll talk more about it. But you need to be familiar with that. Not so much the pathway, but the use of it. You're going to see the air, probably your first choice for community acquired MRSA. Okay. In the GI tract, I mentioned in passing a really problematic agent called VRE, vancomycin resistant enterococci. That came from a lot of these broad spectrum antibiotics, and for people giving people vanco with colitis, and then enterococcus basically became resistant and passed that by way of a transposon on a plasmid to Staphylococcus aureus, and that begat MRSA. What's interesting about MRSA, it's basically found in your nasal passages. That's home for Staph aureus. On your skin, not so much, but in your nasal passages, that's where it grows. It's normal to be there. And a couple of times a year, people in healthcare easily are cultivating MRSA in their nose. It's relatively easy to treat topically there, but that makes you, and that's going to impact you when I talk about that. Down the road, we'll talk more about that. And again, don't use the tetracycline in pre-adolescent children because of their teeth and permanent problems that are associated with there. Vancomycin doesn't work on gram negatives at all. It can't get through that outer membrane. So there aren't a whole lot of always in the world of medicine and pharmacology. That's one. We haven't talked yet about the drug of choice for C. diff. We will. It's a really interesting agent because remember, I told us a little bit about clindamycin. That targets anaerobes and it targets things that get through that glycocalyx, the slime layer, the biofilm. The other agent for anaerobes, and it's much better agent because it has less side effects than clindamycin, though I like both of them a lot, and you're going to learn a lot about it. And you're going to see what's called metronidazole, also known as Flagyl. And it's really the most interesting of the agents because it's double duty. It affects anaerobic metabolism. So anaerobic bacteria, it's a great agent, and anaerobic parasites, it's a great agent. So you're going to see we use it a lot for anaerobic metabolism. When I talk about anaerobic parasites, Trichomonas vaginalis, a very good agent for that. which has anaerobic metabolism. There's a lot of things that contaminate our water, like amoebic dysentery, which are amoeba, which are eukaryotic cells, and giardiasis, which are eukaryotic cells. Those pathogens, and they're nasty. Metronidazole works great. The only problem is headache. But you can even give it to kids. My kids all had to take it when we all got giardiasis from contaminated well water. The big problem with antibiotics in general, gastrointestinal. And and these other areas I will get to, because now we're going into antivirals and things like that. So I will get to these. I'll conclude it here by talking about and separately with regard to the antivirals, okay, that are there. Uh, Again, the most common side effect is gastrointestinal. I'll make special mention of the aciclovirs. Okay, that's Valtrex and which is known as valacyclovir. That's an antiviral. They're nucleoside analogs. Remember that for now before we do our antiviral unit. And we're going to do something about tuberculosis drugs more than once. I mentioned it in passing. When you have tuberculosis, there's a handful we call first and second line agents. We inevitably rotate them every 2 months because of it's extraordinarily resistant over time. And you have to take these medicines for 6 months to a year. So be aware of that. And the other one we're going to talk about a little bit in antivirals is Tamiflu. So Tamiflu is what's called a neuraminidase inhibitor. It's not the only one. So we'll look at both of those that are there. Okay, neuraminidase, it's one of the useful categories. We get the antivirals, you're going to see not a whole lot of players. Okay, we have ones that work for herpes, we have ones that work for HIV, we have ones that work for influenza, and now we have a group that works pretty well on hepatitis C. Other than that, not a lot of love, not a lot of success from those areas. So I'm going to, I believe, stop it here. I don't think there's anything, it might be a little bit more here. I'm just going to double check. Make sure I caught everything. Make sure I caught everything. It's there. You're just about done. Okay. And yeah, and I'll mention one called Synarcid. That's one we're going to get to tomorrow, which will be Wednesday, the 3rd. Synarcid is what's called a streptogramin. It's interesting because it takes two bacteriostatic, they work synergistically, members of this category. And they named it because when you put them together, they actually become bactericidal. And that targets the ribosome, so the protein synthesis, which is unusual for them to be bactericidal, and they were formulated specifically for MRSA. I'll leave you with that. And on that note, I will say goodbye and see you all tomorrow, hopefully in class. Bye.